Welcome to Literature Review Training Session number 5, and congratulations for making it this far. The goals and objective of this module are the following. You'll be able to describe the different study designs that are used to evaluate diagnostic tests. You'll also understand how diagnostic tests are used and the role they play on the clinical front lines. You'll be able to understand the key statistical measures of diagnostic tests. We'll gain knowledge and understanding of the usefulness of the Fagan Nomogram. And finally, you'll be able to grade a diagnostic test study. So what role do diagnostic studies play? First, diagnostic studies can inform replacement. In this case, a new test may replace an old test simply because the new test is more accurate, less costly, or less invasive for the patient. Diagnostic test studies can also inform triage. In this case, a new test is added before an existing diagnostic pathway, and only patients with a particular result continue along that testing pathway. An example of this is HIV, where patients are first screened with an ELISA test, and if that is positive, then an HIV RNA test is performed to confirm the diagnosis. Diagnostic test studies can also be used in the situation of an add-on test. In this case, a new test is added after the existing diagnostic pathway. We do this to help limit false positive or negative results. Diagnostic studies can inform the usefulness of any add-on tests. And finally, they can be used in the context of a parallel or combined test. In this case, a new test, which is intended to be used concurrently with an existing test. Both tests may be used to make the diagnosis. So what are the different types of study designs in diagnostic testing? There are two generic ways to evaluate the impact of a test or diagnostic strategy. The first is that of a randomized controlled trial or observational study. In this case, a target population is randomized either to receive the old test or the new test. Depending on whether the test is positive or negative, the patients are treated accordingly, and patient-important outcomes are then followed. One can now compare the outcomes between the two arms of the study. This is a systematic observation. An example of this is the use of natriuretic peptide to detect heart failure. Patients presenting to an emergency room with acute dyspnea were randomized either to receive the new test, that is natriuretic peptide, or no additional laboratory studies. That would be the old test arm of this diagram. As it turned out, the group that were randomized to receive the natriuretic peptide testing spent a shorter time in the hospital with no increased morbidity or mortality. The second type of study is an accuracy study. In this case, a target population receives both the new test in question and the old test, or the reference standard, sometimes known as the gold standard. The true positive, false negative, and true negative rates are compared. However, it's important to note that assumptions about outcomes is by nature indirect. An example of this is when non-contrast helical CT was compared against intravenous pylography to assess for renal stones. It turned out that non-contrast CT was able to detect more smaller stones than IVP was able to detect. However, because we don't know about the outcomes in either group, and because this type of test strategy is not set up to be a systematic observation, we're not really sure if there's a difference in terms of patient outcomes between using IVP versus helical CT. Let's review some key concepts you'll need to understand to properly interpret diagnostic tests. The first concept is that of sensitivity. Sensitivity is your true positive rate, and a test with high sensitivity is useful to you as a clinician when it is most important to not miss a disease. A test with a high sensitivity minimizes the number of false negatives. A good example of this would be sepsis. You'd want your test for sepsis to have a very high sensitivity because missing sepsis could lead to dire consequences for your patient. The next thing to understand is that of specificity. Specificity is an expression of the true negative rate, and it's most useful to you when you want to avoid false positives. A good example of this would be breast cancer. You would want your test for breast cancer to be very specific because giving the wrong diagnosis to the patient could cause a tremendous amount of stress for them. Additionally, the wrong diagnosis could lead to unnecessary testing, such as surgical biopsies, which could increase the patient's morbidity. Positive likelihood ratio. What does this tell you? What a positive likelihood ratio tells you is that when a test is positive, it tells you how much to increase the probability of having the disease. So, likelihood ratio is a way to express the change of odds from pre-test to post-test probability. Negative likelihood ratio. What a negative likelihood ratio tells you is that when a test is negative, it tells you how much to decrease the probability of having the disease. Positive post-test probability. What this is the probability that a person testing positive has the condition. This is also known as the positive predictive value. Negative post-test probability. The negative post-test probability is a probability that the patient testing negative has the condition. This is essentially the false negative rate. Pre-test probability and prevalence. This is the probability of a patient having the target disorder before a diagnostic test result is known. In the general population, this is known as the prevalence. The pretest probability is also an expression of your clinical acumen. For example, if a young patient presented with tripoding, drooling, fever, and severe sore throat, your pretest probability that they would have a bacterial infection, such as a retropharyngeal abscess or epiglottitis, would be very high. On the other hand, a patient who has a mild sore throat and no fever, no drooling, and no severe symptoms would have a low pretest probability of having epiglottitis. Let's examine the likelihood ratio a little more closely. A likelihood ratio of 1 has little use because it doesn't change the post-test probability. In general, positive likelihood ratios greater than 10 and negative likelihood ratios of less than 0.1 are most useful to you clinically. You can use this quick reference table as a guide. In terms of positive likelihood ratios, a large shift in post-test probability would be seen at a positive likelihood ratio of greater than 10. A moderate shift in post-test probability would be a positive likelihood ratio between 5 and 10, and a small shift in post-test probability would be a likelihood ratio between 2 and 5. In terms of a test's ability to rule out a disease, that is, the negative likelihood ratio, a large shift in post-test probability would be negative likelihood ratios less than 0.1. Let's see how these numbers are calculated, starting with sensitivity and specificity. All important statistical calculations and diagnostic test studies arise from this 2x2 table, the table that shows the number of true positives, the numbers of false positives, the number of false negatives, and the number of true negatives. If you wanted to calculate sensitivity, you would do so in the following way. You would take the number of true positives and divide that times the number of true positives plus the number of false negatives. Specificity would be calculated by using the true negatives and dividing that by the false positives plus the true negatives. Remember that the sensitivity and specificity are characteristics of the test itself. It does not predict the likelihood of patient outcomes. Positive predictive value and negative predictive value can also be calculated using the 2x2 table, and the formulas are shown there. The positive predictive value is a chance that the patient testing positive for the disease actually has the disease, and the negative predictive value is the chance that the patient testing negative does not have the disease. Keep in mind that when you're evaluating the positive and negative predictive value, this estimates the likelihood of the outcome in your particular patient for that disease prevalence that was found in the study from which this data arose. Positive and negative post-test probability, as well as positive and negative likelihood ratios, can also be calculated from the data found in the 2x2 table. So here is a summary of the calculations needed to calculate all the important statistics in diagnostic test studies. You can keep this as a reference, but also note there are a number of online calculators which we will provide links for you that can do this more quickly than you might be able to do it by hand. Let's use the Fagan Nomogram. The Fagan Nomogram draws relationships between the pre-test probability, the likelihood ratio, and the post-test probability. Let's take our first example. Say, for instance, the pre-test probability of disease is 60%. A clinical example of this could be, in New York City during the height of a COVID crisis, a 60-year-old patient who presented to the emergency department with fever, cough, and shortness of breath may have had a pre-test probability of up to 60%. Say you had a test, for example, a PCR study, that had a positive likelihood ratio of 10. Let's use the Fagan Nomogram to determine the positive and negative post-test probability. Starting on the left side of the nomogram, at a pre-test probability of 60%, we can draw a straight line through the positive likelihood ratio of 10, which ends up at 95. 95 is the positive post-test probability. This means that there's a 95% chance that the person testing positive has the disease. Let's use the nomogram to help us give us more information about the interpretation of a negative test result using the negative likelihood ratio. Say, for example, the pretest probability of disease is 60%. We draw a straight line through the negative likelihood ratio of 0.5, and we end up on the post-test probability line at about 40. 40 represents the negative post-test probability. This means that there's a 40% chance that the person testing negative for the disease has the disease. Let's now examine how the change in the pretest probability affects the positive and negative post-test probability. An example of where the pretest probability or prevalence of the disease may be lower than 60%, in this case 1%, would be the clinical scenario, for example, where an asymptomatic young person gets tested for COVID-19. Using the same positive likelihood ratio of 10, we use the Fagan Nomogram. And as you can see, a straight line drawn from 1 through a positive likelihood ratio of 10 ends up on the number 10. This is the positive post-test probability. This means that there's a 10% chance that this person who is tested positive has the disease. We can do the same thing for negative likelihood ratio. Again, starting at a prevalence of 1%, drawing a line through the negative likelihood ratio of 0.5, we end up with a number of about 0.4. This means that there's only a 0.4% chance that the person testing negative has the disease. So this illustrates the importance of pretest probability and its effect on positive and negative post-test probability. What we want you to take away from this lecture is that the positive and negative post-test probabilities are highly dependent on the disease prevalence, and that rare diseases or diseases with low prevalences in the population are harder to detect. Let's return again to the Fagan Nomogram, and again revisit the example where the pretest probability was 60%. The blue line indicates the positive post-test probability, in this case 95%. To review, the positive post-test probability is the probability that the patient testing positive has the disease. This means that there's a 5% false positive rate, which as a clinician you'll likely accept. Now let's look at how we might interpret the negative test result in the case where the prevalence is high. The negative post-test probability is 40%. This is the false negative rate, whereas the true negative rate is 60%. This is important from a clinical standpoint. For example, say there was an effective therapy for the disease process in question. The high false negative rate may mean that you might still want to give that therapy to that patient, especially if there's a high likelihood that that treatment is beneficial. Now let's turn to the example of a pretest probability, in this case, where the pretest probability is low at 1%. The green line indicates the positive post-test probability, in this case, 10%. This means for low disease prevalence for this test, 90% of the time, the result that's positive will represent a false positive. This also has important clinical implications. In the case of infectious diseases, you might not want to go through the same amount of rigor in terms of your infection control procedures if the false positive rate is very high. However, such a decision would need to be weighed against the 10% true positive rate. So from an infection control standpoint, despite the fact that the false positive rate is high, you may still want to be very rigorous with your infection control procedures. Let's examine the negative post-test probability in the setting of a low prevalence. In this case, the false negative rate is 0.5%. This means that the true negative rate is 99.5%. So in this case, you are very reassured from a clinical standpoint if the test is negative. So think about the Fagan Nomogram and how the relationships between pre-test probability, likelihood ratio, and post-test probability all come together to help you make the right decision for your patient. Let's talk about grading diagnostic test studies. The factors that decrease the quality of evidence for studies of diagnostic accuracy may be different from those factors that decrease the quality in treatment studies. And in this table, published by Schoenemann in the British Medical Journal, the researchers describe some similarities and differences. Let's start with study design. In diagnostic test studies, high-quality studies are cross-sectional or cohort studies. In studies looking at treatment, these would be considered more low-quality evidence. In diagnostic test studies, in terms of study design or risk of bias, a low risk of bias would occur in a situation where consecutive patients are recruited in a single cohort, and those patients are not classified by disease state. This is different than how you would evaluate risk of bias in a treatment study. In addition, selection and referral processes should be clearly described in diagnostic test studies. And also in diagnostic test studies, both the test in question, the new test, and the reference test should be done in both patients. You would not want to do this in a treatment study. When evaluating indirectness, imprecision, inconsistency, and publication bias, the criteria between diagnostic test studies and treatment studies are largely the same. Please refer back to this this chart, it can be very helpful when you start grading diagnostic test studies. The Quadis tool is a helpful tool to assess risk of bias and indirectness in diagnostic test studies. The Quadis tool is split up into 4 domains: patient selection, index tests, reference standard, and flow and timing. In assessing risk of bias for patient selection, you'd want to check if a consecutive or random sample of patients were enrolled. You'd also want to check if a case control study was avoided and whether or not the study avoided inappropriate exclusions. Based on these 3 criteria, you would then make a determination if there was a high, low, or unclear risk of bias. In terms of the index test, you want to see whether or not the index test results were interpreted without knowledge of the results of the standard or the gold standard. And if a threshold was used, you'd want to check if it was a pre-specified threshold. In terms of the reference standard, you'd want to check whether the reference standard was actually likely to correctly classify the target condition. In addition, you want to know whether or not the reference standard results were interpreted without knowledge of the results of the index test. Flow and timing is also important when assessing the quality of a diagnostic accuracy study. Check whether there is an appropriate interval between the index test and the reference standard. Make sure that all patients receive the reference standard and that they all received the same reference standard. And finally, be sure that all patients that were in the study were included in the final analysis. Applicability is applied at all levels, as shown in the diagram. So here's a summary table of how diagnostic test studies may be different from treatment studies in terms of grading, and also how diagnostic test studies might be similar to treatment studies in terms of grading. In order to understand imprecision, you first have to understand the harms of both false positives and false negatives. Let's start with the harms of false positives. In false positives, you could have harm from unnecessary treatment. So for example, in the case of breast cancer that we talked about earlier, the harms from unnecessary treatment could be the harms from unnecessary biopsies or other procedures, or even unnecessary chemotherapy. You can also generate harms from false positives from having unnecessary testing. Sometimes the test itself may be risky. For example, a sedated MRI requires anesthesia, which in itself carries risk. Another significant harm of false positives is that harm of the stress of thinking you have a disease, especially one with a poor prognosis. And finally, a harm of a false positive could be population effects, such as harm from poor antibiotic stewardship, in the case where a diagnostic test study has a false positive and indicates that the patient has an infection when they actually don't. These types of population effects can also include wastage of healthcare resources. So what are the harms of false negatives? The first obvious harm is that from having the misdiagnosis. We talked earlier about the example of sepsis. Missing sepsis in a patient can be very, very dangerous for that patient and could even result in their death. Another harm of false negatives is the reluctance to retest. By not retesting, you may actually miss a diagnosis that actually exists. Let's take a look at a clinical example illustrating how you might evaluate a diagnostic test study for imprecision. In this case, we're going to assess your clinical decision threshold for false positives. The relationship between the clinical decision threshold and the confidence interval will determine whether or not you deduct points for imprecision. Say for example, your positive post-test probability, which remember is the percentage of patients with a positive test who have the disease, for a clinical dehydration score, so that's your diagnostic test, to diagnose a patient with 3% clinical dehydration is 25%. And the confidence interval around this positive post-test probability is between 12 and 38%. What this represents is a true positive rate of 25% and a false positive rate of 75%. Now is the time you determine the risks of false positive. In this case, the risk of a false positive may be that from unnecessary treatment. For example, starting a peripheral IV and giving IV fluids. Now, you need to determine what your tolerance is for false positives. And this is your clinical decision threshold. So say you determine your threshold is 50%. You would accept a false positive rate of 50%. Since the confidence interval is 12 to 38%, the clinical decision threshold of 50% does not cross this confidence interval. So therefore, there's no imprecision. On the other hand, say you determine that your clinical decision threshold is 25%. In this case, 25% crosses the confidence interval, and therefore you judge this to be imprecise. Let's look at how you would assess for your clinical decision threshold for false negatives. So say, for example, you have a negative post-test probability, and remember, this represents the percentage of patients with a negative test who have the disease. For the clinical dehydration score is 10%, and the confidence interval is between 5 and 15%. And remember, this is the false negative rate. So in this case, the risk of false negatives is harm from missing the disease state. And in this case, it is 3% clinical dehydration. So say you determine that the risk of missing this particular condition is relatively low, and that you would tolerate a false negative rate of 70%. Now, since 70% does not cross the confidence interval, you would not take a point off for imprecision.